Good afternoon, everyone, and as always, thank you so much for joining in today. I'd like to start by extending a very big thank you to the California Medical Association and California Health and Human Services for sponsoring this virtual Grand Round series, and give a special thanks to the amazing CMA team that supports this broadcast and leaders like Drs. Carol Glazer, Dr. Erica Pan, Dr. Jen Babick, and Dr. Alice Chen, who help with the idea generation, gathering our speakers, and generally putting it together. I'm Dr. Kim Newell-Green, and as usual, I'll be the moderator for today's virtual Grand Rounds, which is entitled COVID-19 and the Holidays, Where Do We Stand? Updates on Epidemiology and Outpatient Treatment. I will note that we had originally had a speaker to talk about testing today, but he was unable to make it, and we will reschedule him for another time. Next slide, please. Here are our disclosures today. Take a look at that. Next slide, please. And this is our agenda. We're very excited about our speakers. I'll tell you about them in a moment. Next slide, please. And just to note that, as usual, we will be offering continuing medical education today. You will be sent a survey after the completion of the webinar, and just remember, you do need to attest your attendance in order to get your certificates. As we navigate this year's holiday season, the choices feel very different from those in 2020. Despite the news of a new variant called variously Omicron or Omicron, I'm told that both are okay. More people are traveling and choosing to gather with family and friends to celebrate. And still, many of us are moving forward with some trepidation. As we make our own decisions and we counsel our patients about whether to travel and gather, it's essential that we have a full understanding of the local COVID-19 conditions, including vaccination and booster rates, confirmed cases and hospitalization rates, and the status of the variants. And as clinicians treating COVID-19, this is also a very different time from December of 2020. It's very exciting that we have many more options in terms of therapeutics. And finally, some outpatient treatments are available now, and more are likely coming soon. So in this virtual Grand Rounds, we'll get our usual amazing update from Dr. Erica Pan on the status of COVID-19 in California. Dr. Pan's presentation will be followed by the presentation by Dr. John Openshaw, who will introduce us to the state programs that make outpatient monoclonal antibody therapy widely available. On the subject of outpatient therapeutics, we'll also hear from Dr. Annie Lutkemeyer from UCSF, who will further educate us about the injectable monoclonal antibodies. And if there's a time, she'll also discuss the newly available or soon to be available oral therapeutics. I'd like to mention here that as a preview to January, we will have another expert, Dr. Sarah Dornberg, talking in January in more depth about the oral therapeutics next month. During these presentations, please do submit any questions you might have using the question box in the control panel that's located on the right-hand side of your screen, and we'll go for as many as we can. For our first two presenters, we'll welcome back Dr. Erica Pan, our regular guest and the California State epidemiologist, who will then be followed by Dr. John Openshaw. Dr. Openshaw is the lead of the COVID-19 clinical work at the California Department of Public Health. He's also a professor of medicine and infectious diseases at Stanford, where he's a senior fellow at the Center for Innovation in Global Health at Stanford University School of Medicine. He has long been interested in the intersection of infectious disease and ecology, and is engaged in research detecting emerging zoonotic pathogens in far-flung places such as Bangladesh, China, and Costa Rica. Welcome, Dr. Pan and Dr. Openshaw, and thank you so much for being here with us today.
Great, thank you so much, Kim. So I will go ahead and get started. And you know, considering how much has changed in the last week and a half since Thanksgiving Day, I thought I would spend a lot of my portion today to really update everyone on Omicron or Omicron, depending how you decide to pronounce it. Next slide. Next slide. So again, we'll talk a lot about the Omicron variant and how it's evolved, and then the overlap with that and the epidemiology in California. I'll have a little bit of some key kind of updates on testing. And as mentioned, I know there's going to be a deeper dive, and I have no Michael Mina, but looking forward to having him come back in early 2022, but can tell you a little bit about some of our strategies here in California. And then I'll turn it over to Dr. Openshaw to talk more about therapeutics in California. Next slide. So talking about Omicron, what happened when, why is this important? So in South Africa, there was an increase in cases, a big cluster outbreak among some university students that they noticed in the province of Gauteng. And this is the province where Johannesburg is. And this new variant, as far as the pangolin nomenclature, is B11529. And they noticed, again, a big cluster in South Africa, and around the same time in Botswana, and then soon after that in Hong Kong, there was a traveler from South Africa that was identified, and you'll hear more about that traveler soon. But there were early signs from the labs there that this variant was rapidly increasing. And then I'll show you sort of, let's go to the next slide. They soon noted it in all of their provinces. So again, around November 24th was when this was first reported to the World Health Organization by South Africa. By the next day, last Friday, well, 2 Fridays ago, it was designated as a variant under investigation. Actually, I may have the days of the week off, but anyway. And then the 26th, the World Health Organization also classified this as a variant of concern and named it Omicron, following through the Greek alphabet. And by the next day, Omicron had been confirmed in 8 countries. And then a few days later, last Wednesday, we had our first case confirmed here in California, and that was the first in the US identified. And this was in a traveler from South Africa to San Francisco. If you look at this graphic here on the upper right, this is basically what they were seeing in South Africa. So they were seeing a new increase in S gene, what we call S gene target failure, which I'll describe a little bit more later, in mid-November. But as you can see, it was a pretty dramatic increase that they were seeing in their cases. And that was first again noted in that province of Gauteng. And then when they started to look at that particular characteristic of PCR data in all the provinces, they were seeing a big increase. And then this lower graphic shows you from nextstrain.org, sort of how the variants have evolved over time in South Africa. So they certainly, like the rest of the world, had really been predominantly Delta most recently, but already as of whenever this was pulled in Africa, they were seeing a third of what they're sequencing is actually Omicron. And this is in the 21K clade. It's very, very different and further on the genomic tree away from all these prior variants of concern that we've seen. And there may be some biases on who's getting sequenced, certainly, as far as this proportion, but it seems to be rapidly overtaking or increasing in the midst of Delta in South Africa. Next slide. So why were people so much more concerned about this particular variant versus other variants of concern? It has many more mutations than any of the other variants of concern that we have seen, including Delta. There's over 50 or so alone in the spike gene area. And these mutations there have a lot to do with transmission, so that's why everyone's concerned that it could be more transmissible. These characteristics also lead to how well the virus binds with our ACE receptors and also our fusion. So those also could translate to different severity of disease as well, and so those particular mutations are a big concern. There are many of these mutations that we've seen in other variants on their own, and then there's many new ones that are still being kind of looked at as far as what is their phenotypic impact or what's their actual impact. The other concern, of course, is that they may reduce neutralization by antibodies, whether it's your own antibodies from prior infection, from vaccination, or even monoclonal antibodies. So there isn't a lot of data yet, but again, a lot of those mutations are predicting a poor response to those things. And then this deletion, a specific deletion that keeps being brought up in the S gene, really helps us as far as screening for this particular variant. But it is seen in some other variants as well, but not typically in Delta. Next slide. So again, this was really just noted by the World Health Organization, as mentioned, around November 26th. And by yesterday, we have now seen this all over the world We have over 56,000 cases, I think, that have been detected. The biggest proportion of those have been in South Africa, but rapidly increasing in South Africa. And then, you know, I think we're over 130 or so other cases around the world. And, you know, this is immediately outdated as soon as you pull the data. But there's a nice link here if you're wanting to look at what's already been confirmed and then what's presumptive based on that S gene target failure. Next slide. So what about here in California and the US? We have at least 10 confirmed Omicron cases. Again, everything is out of date. As soon as we finalize the slide, we're certainly hearing about others that are under investigation right now or getting sequenced now that have high suspicion based on travel exposures or other screening criteria. You know, of note as well, in the Alameda County outbreak, there are 12 cases actually associated with an outbreak there. There are 5 confirmed. Some of the other 5 that are in the lab are still pending. It's also of note, I think most of these cases, again, have been travelers, have been people under the age of 50. Many have been vaccinated, and there's obviously some selection bias in that. If you're healthy enough to travel, and if you're traveling, you in many countries have to be vaccinated to come there. Many of these cases in this Alameda outbreak were boosted. I think also important to note, though, there have been no hospitalizations, certainly in this outbreak and any of the US cases that we've heard about. Many of these were boosted. They all had mild symptoms. And then there are additional contacts that are being identified. And the exposure event for this outbreak was actually a wedding that they all traveled to in Wisconsin on the 27th, and then have since come back and tested here. The suspected index case in this outbreak had recently returned from Nigeria on the 24th. There were no other international travel exposures reported to date in this investigation. Also really interesting to note our wastewater surveillance, which has been increasing around the state and around the country as a way to detect new variants, or certainly as we get to lower levels, trying to detect early increases. But we have seen in a couple different areas in Sacramento and Merced. Sacramento had a couple different signals. First, they found that specific S gene deletion or mutation, that S gene target failure. And then actually more recently that has been confirmed. So this is certainly suggestive, even though we haven't had any clinical cases reported in those counties yet, that there is virus circulating there as well. So we will continue to monitor this with our academic partners and with the local health departments, but we definitely are seeing Omicron, you know, across the state for sure. Next slide. And then this is a really nice kind of genomic tree to look at the whole genome sequencing and how these cases are related to each other. And again, this is already outdated. I've seen a newer version of this morning that has 33 US cases, and they're all sort of map out on a tree like this, and you can see where our California cases play out here. And I think we're certainly working with other states sometimes when they look closely related to see if there is any connection as far as the same flights or similar travel or exposures. But we will be continuing to use this data, and we've made so much progress over this pandemic actually to coordinate looking at the whole genome sequencing and then the epidemiologic data as well to really investigate these outbreaks and relatedness of different isolates. Next slide. I think as far as transmission, so again, there's obviously a lot of questions about this, and as I mentioned, concerns based on where those mutations are. One key report that came out about the traveler in Hong Kong was that the initial case was identified, had been quarantining, had tested negative 72 hours before coming, so before they got on the plane, was in the hotel, the Hong Kong hotel quarantine, and then across the hall there was a traveler from Canada who had been there actually a day before, but they were confined in their rooms across the hall from each other, and they actually have you know, surveillance cameras as well, and they've confirmed that these two individuals did not interact with each other, were never in the same room together, but then the person coming from Canada developed symptoms about 4 days after the other index case A. And so the thought is that this infection happened just from airborne transmission across the hall. So certainly suggestive of a very infectious and contagious variant of this. And when they did the whole genome sequencing, they only differed by one nucleotide, which also suggests that they were related to each other. So this is certainly an indicator, and there are some estimates out there that maybe the R effective is as high as 3. I think, again, more data needs to evolve before we will really say how infectious this is, but lots of concerns about that. Next slide. So along with learning more about transmissibility, we want to learn more about disease severity, about the impact of vaccines on testing, the risk of reinfection, and also treatments, which you'll hear a lot more about after I speak next. Next slide. Again, it's very, very early for all of these different areas, but we do know that the variant has infected, again, fully vaccinated persons, including boosted persons, and there's more, and I'll show you one recent publication about reinfection as well, and seeming to potentially cause more reinfection than prior variants. But there really is not a lot of systematic collected data yet, as again, it's a very, very new variant. So we need to really be able to describe the spectrum of the signs, symptoms, and severity. The South African Public Health Authority has not officially reported any worrisome increase in hospitalizations or ICU admissions or deaths, but again, it's very early. Most of the cases that they have reported, the epi has really been, again, in young adults and travelers. So I think we're really waiting to see what about the elderly, what about the immunocompromised? Are they going to have more serious illness? But again, most of the anecdotal reports are mild illness. There was also a recent report, we didn't put the link in here yet, but from the South African Medical Council about one of their large medical wards where they're seeing less oxygen requirement, less ventilation during this wave, even they're seeing a huge increase in cases, but in their wards, there are less respiratory symptoms as well. And many of the people have been identified as sort of screening testing upon hospitalization, but not being hospitalized for COVID. So I think that's also important to note. And again, more data will come out, I'm sure, every single day to really help us understand the spectrum of clinical illness. Next slide. This is a nice slide the CDC put together based on the South African surveillance reports comparing. You can see this orange line here is the rapid increase in cases over the last sort of week and a half, 2 weeks. So again, rapid rise in cases, but if you look at and somewhat of an increase in their hospitalizations, but as I also mentioned, their narrative reports on this are that many of those hospitalizations are people who were incidentally tested and not admitted for COVID. And then if you look at ICU, which is the gray, that's the percent hospitalized and is the gray, and then the yellow is percent hospitalized and ventilated. Those are actually pretty stable and not increasing in the same way that cases are. Again, often hospitalization is a lagging indicator, takes 2 or 3 weeks after an increase in cases to really see. So it's early, but we are hoping that these are early signs again that are promising. And as I mentioned before, I want to reiterate, this has also mostly been younger adults. So I think, again, we'll need to see over time what other data comes to bear. Next slide. So what about Immunoscape? Again, the mutations themselves are concerning because of their location and because some of them who have been studied in other variants. So many studies are pending. Our understanding is another week or two, we'll have a lot more of the in vitro data about neutralizing antibodies from convalescent sera and from vaccinated persons' sera. But the expectation is that there will be decreased neutralization from antibodies from vaccine and prior infection, but cellular immunity should be robust, is what we're hoping again, and more study both just in the field clinical data and also in vitro data will be helpful to see what happens with cellular immunity. But we're hoping that that will actually hold strong, and that's what's keeping it to be a milder disease, because that's really what protects us in our lungs and from a lot of the respiratory and systemic illness. And then as far as reinfection, some of this early data again suggests a higher reinfection rate compared to prior Delta and Beta waves, which suggests some immune evasion from prior infection. Next slide. So on that note, there was a recent preprint from South Africa, and you can see here, and kind of the bottom lines on this are that the wave 3 here in orange was the Delta variant, and the reinfection rates were pretty flat, but they're seeing an increase in reinfection rates here in green. And when they compared reinfection rates from what's happening currently to the prior waves, there's over a 2 times higher risk of reinfection currently compared to prior waves. So that is again suggestive of evasion of immunity from prior infection. Next slide. So what about testing? So again, PCRs are detecting. There's no concerns that we won't be able to detect the Omicron variant with PCRs. There's a specific manufacturer and type, a TACMAN PCR from Thermo Fisher, that uses 3 targets, including that S gene. And if there's only 2 of 3 of those targets are positive and the S gene is negative, that is an indication of in screening and what they were using in South Africa to be kind of a presumptive Omicron. There are, it's rare, but there are some other variants that have that same mutation. So really you need to see the final whole genome sequencing before you can be sure, but it's a helpful way to prioritize whole genome sequencing and also do some initial screening. There's also something called single nucleotide polymorphism SNP assays that are also that we've used in the past to help screen for certain mutations, and there are some that are in development specifically for Omicron and to compare Omicron versus Delta that can be more rapid than the typical whole genome sequencing turnaround time. And then the other big question that's been coming around is, are antigen tests impacted by this variant? Are we going to miss it by doing antigen testing? I haven't seen any sensitivity or specificity data specifically, but as far as in general, is there concern about them missing this particular virus and variant? And the answer is not so far. The FDA has been evaluating that and looking at these tests. And the other issue that people brought up is the nucleocapsid protein target for the antigen test is a much bigger target and doesn't have as many mutations in this particular variant. So far, the antigen tests are holding steady in being able to detect this variant. Next slide. What about international travelers? What has been some of the federal response to this? As of December 6th, all international air travelers, regardless of their vaccine status, must show a negative COVID-19 test within 1 day before travel to the United States. So prior to this declaration, there was a little bit more, there was some variation depending on citizen status or not, and also people were allowed to test within 72 hours, but given many of these cases that were negative prior to getting on the plane and then became positive later, they have tightened this requirement up. And so the recommendation is that all travelers should get tested with either PCR or antigen test, and again, to be timely, often it needs to be an antigen tested to get it done quickly with quick turnaround time, but 3 to 5 days after travel. And of course, monitoring for COVID-19 symptoms, isolate and get tested if symptoms develop. And then for people who are not fully vaccinated, they need to self-quarantine for a full 7 days after travel. And it's still recommended that they test at 3 to 5 days, but to stay in quarantine until that full 7 days. And of no testing to quarantine for 10 days after travel. So the other question, of course, that also has come up is, should we be treating these identified cases differently than Delta variant or prior variants as far as isolation or quarantine because of concern until we know more? And currently the CDC and CDPH recommendations are to use your current isolation and quarantine guidance. One thing that we have recommended though more recently is that close contacts should get tested as soon as they're identified, which there's a huge variability as far as when they get identified and when their last exposure was, but immediately upon identification and then 3 to 5 days later after the last exposure. Unvaccinated contacts still need to quarantine. We have not said that vaccinated contacts should quarantine, although obviously in certain sensitive occupations or settings or certain higher risk situations, local health departments may use stricter requirements either as a blanket policies or in specific situations. And then the other thing we have mentioned to our healthcare partners that healthcare workers in sensitive settings, more frequent testing is encouraged. So if you have a healthcare worker who's been a close contact, consider testing them every day or every other day, especially if you're having staffing shortages but want to have them working. So that's another tool you can use to help just have early detection. Next slide. So where are we as a state in general as far as our cases, hospitalizations, and ICU? So I think I show this to you every month when I'm here, and you can see in this blue line we have I think that's our cases, and you can see we definitely had a dip in the Thanksgiving holiday, which I think certainly was a decrease in testing in itself and reporting, and then an increase. So we are certainly seeing a post-Thanksgiving bump in our cases. Right now, our hospitalizations are looking relatively stable as far as COVID, although you can see that maybe they're on a slight increase. Deaths, thankfully, are still decreasing, although again, that's often a much time lag after we see increases in cases and hospitalizations. And then ICU is remaining steady as well. Next slide. And then what about test positivity? This is something we've also been looking at as an indicator to really pay close attention to. And we did see during really low testing volumes a bump above 3% in test positivity statewide, and now it's back to the low 2s. I think this is still sorting itself out, certainly with a lot of fluctuation of holiday testing. And we saw that even last year over the holidays, a lot of ups and downs, and actually all of the holidays over 2021 as well. So we are, again, watching this closely as far as testing volume and test positivity. But it is something that can often be an early indicator as well if you see test positivity increasing, especially if there's not a big change in testing volume, as an early indicator that cases are going up. Next slide. And then what about our overall hospital census? I think this is what the healthcare systems and we are paying really close attention to, especially as we embark here in early December, right before the winter holidays with the colder weather, more indoor activities, more gatherings, even pre-Omicron being potentially more infectious. We were very concerned about this. In the lower right-hand corner, you can see the whole state of California. And to orient you, the upper blue line is our overall hospital census, so all hospitalizations, not just COVID. And the dashed lines are an estimate of 10 and 20% above kind of what we're calling a baseline hospitalization. So the lowest sort of levels we've reached prior last fall and also this summer are what we were calling around 100% as a baseline of how full hospitals are outside of that and when they have just a smaller proportion of COVID patients. So again, that second dashed line is 20%. And then the lower colored peaks are actually percent of COVID patients. So the dashed line is at 20%, because certainly during our winter surge a year ago, all of the regions showed over 20% of their overall hospitalizations for COVID. And that certainly is something that has put regions and the state over that 20%, which is really kind of a real stretch as far as our mostly staffing. I think we have space, but staffing is, as you all know, really the biggest consideration with staffing shortages and healthcare worker fatigue over time. So we are still close to 10% over our baseline. And again, we're seeing some small increases in flu and bigger increases in RSV. So just very concerned about and watching this closely. And you can see the other regions, some are either 10 or even as high as 20% in the San Joaquin Valley above kind of their usual lower numbers. Next slide. So this is our big unknown, right? Last year we did hit sort of a tipping point, especially in certain regions and largely based on COVID. And now we have a lot more non-COVID patients in the hospital, and how much more can we absorb as far as COVID patients? And this is again in the face of a more open society than last winter, in addition to a higher burden of non-COVID hospitalizations. So we are meeting frequently with regions, providing staffing support in some of the areas that are already having challenges, and again watching this closely as far as winter hospitalizations. Next slide. And then shifting to vaccines. So we really know, again, our best tool and our long-term tool is vaccination. So you can see over time, working from a year ago, and we're going to hit our anniversary, I think next week, of our first vaccines here in California. And you can see over time that now we've had another bump, at least in boosters, which is the green. And also, of course, our 5 to 11-year-olds are now eligible. And so a lot of those first doses in the blue there are new 5 to 11-year-olds getting vaccinated. So this is kind of a snapshot in the table here that we have boosted at least a third actually today of our 18 and overs that are eligible for boosters as far as the time period, and then 56% of our over 65. So that is good. We still need to make more progress. Some of our modeling showed we really want to have 40, 50, 60% of people boosted to really address the waning immunity. And then also excited to say that in our 5 to 11-year-olds, we are getting close to 19%. So again, making slow and steady progress on getting our 5 to 11-year-olds vaccinated. And overall, you can see other progress in our different age groups. Next slide. And then testing, again, I know there will be a future focus, and look forward to having Dr. Michael Mina come back, but we really do want to, and you've seen some announcements from the federal government as well, to increase access and use of testing. And as far as recommendations, we are definitely saying before and after travel, as I just mentioned, and that can and should be for domestic travel as well. And then also before gatherings and mega events. So in my family, we tested everyone before we were going to have the Thanksgiving gathering because we had a lot of elderly people there. And there are some requirements for vaccination or testing before mega events as well. As far as our airports, you've heard a little bit about probably heard a little bit about the CDC piloting in 4 different airports, including San Francisco. And we also, in California, there was also a state-run airport pilot at San Francisco, and now LAX is doing airport testing, and more of our other airports are coming online to, as people kind of come into California off the planes, that they see these booths and places, and they can, in a couple of these, we're working on testing on site. That's what's happening in LA. And then also people can get these at-home test kits to take with them to, again, just really increase detection. And then these antigen cards for the take home, if there's someone that's positive, we can actually send them and get them sequenced to look at what variant is there. As far as schools as well, there's ongoing, as you all know, a lot of screening, periodic testing at schools to really help do kind of ongoing testing in the schools and response testing when there are cases or outbreaks. And then we just did a big outreach on a safe return from holidays program, and we've ordered, I think, over 2 million, and I think it's actually increasing next week. A bunch of kits will go to schools that are interested to give those to families so that they can test themselves at home before coming back after the holidays. So very excited about that initiative, and excited about the federal efforts as well to improve access. And we are working really hard to think about equity as well, and access to testing in our harder hit communities, because as we all know, the over-the-counter tests are still very expensive. So working on more projects and more to come on that. Next slide. And then as far as our whole genome sequencing, just want a huge shout out to California has been a leader in this as well. We've had something called COVID-19 that was started very early in the pandemic in 2020, and it's an amazing partnership with a lot of our different partners, our viral rickettsial disease lab, the Chan Zuckerberg Biohub, our local public health labs, UCs, and other academic institutions like the Scripps Institute, and other diagnostic laboratories. And then of course there are CDC partnerships that feed into this as well. And this has really helped us have a very robust sequencing in California. We have to date sequenced over 225,000 isolates. At our peak during the Delta surge, we were doing over 50,000 a month. We have capacity to do up to 18,000 a week. And we've been sequencing about anywhere from 14 to 23% of our cases in recent months. And this is just a snapshot, kind of analogous to what I showed you for South Africa, still the largest proportion, and well over 96 to 99% of what we're seeing in California is Delta, but I showed you we are seeing the emergence of Omicron. Next slide. And then a last little tidbit, just because I think we've all been asking a lot of questions about, how we're learning more and more about long COVID and long-term symptoms after COVID, and how does vaccination play into that? And there was a relatively recent publication that looked at one dose of any of the 3 COVID vaccines prior to diagnosis with COVID-19. And anyone who had been vaccinated was 7 times less likely to report 2 or more long COVID symptoms compared to unvaccinated patients. And it does look like vaccination before or after COVID-19 reduce the risk of long COVID. So the link is in here as well if you want to take a deeper look at that. But I think it's yet another reason really to continue to push vaccinations. There's a lot of advantages of getting vaccinated even if you've been infected in the past. Next slide. So the bottom line is, and in thinking about the holidays, to just circle back to how Kim started us off, our recommendations are actually the same. We do have a new variant in our midst. We're learning a lot about it every moment, but our best tool and our long-term tool is to get vaccinated or boosted. And as long as we have large proportions of people unvaccinated, that is what will drive transmission and drive new variants. So we need to increase vaccination to limit that emergence. So again, get the whole family vaccinated, get those 5 to 11-year-olds vaccinated, and get boosted if eligible. And then really making sure people are thinking and using their masks well, making sure they have a good fit and filtration, upgrading to good filtration, especially in indoor settings and in crowded settings. Talked a lot about testing. I think we can continue to use this as a tool to really try to have early detection and keep people away from others once they're positive. And then really important to stay home if you're sick and get tested, and not try to come to work. And if you think you just have allergies or the sniffles, it's really non-specific. And especially with Omicron, we don't know. So the best thing to do is to get tested and be sure whether there's a lot of other respiratory viruses certainly circulating. So the best way to know though is to get tested. Next slide. And with that, I will turn it over to Dr. Openshaw, who has been amazing, helping lead a lot of our clinical evidence about how we're learning about emerging science around COVID-19, but also really working closely with our logistics team about how we are thinking about therapeutics as they come into California and how we distribute them. So Dr. Openshaw, I will turn it over to you.
Thanks very much. And I'm going to take the next 10 minutes or so to go over the therapies that are coming down the pipeline and the state's plans for distribution and talking a bit about that. If I could have the next slide. I know that there's another speaker following me who's going to talk about some of the clinical aspects of these therapies. There's a lot of detail in these slides. I'm going to run through some of them fast because I think later on in this grand rounds, they will also be discussed. This first slide does show you the therapeutics that we currently have available. This is divided up by disease state along the top, and then shows currently available therapeutics and therapeutics that EUAs are pending that we probably will see in the near future. Just starting with those who are infected, these therapies are for outpatients and they're for treatment of mild to moderately ill outpatients. And currently we have 3 monoclonal antibodies used for treatment of mild to moderately ill outpatients. Those are Bamedi, REGEN-COV, and sotrovimab. 2 of those products, Bamedi and REGEN-COV, can also be used as post-exposure prophylaxis. And that really is the extent of our currently available outpatient COVID-19 therapeutics. The bottom row shows some of the new products that are coming down the pipeline, as well as some of the probably first indications. Some of these indications may change or indications may be added as new trial results become available. But you've got 3 exciting new products that are coming. The first, the AstraZeneca long-acting monoclonal, is likely going to be the first product for pre-exposure prophylaxis. So that's going to be used in individuals who are not exposed and high risk of not responding to vaccine. And then you've got Molnupiravir, Paxlovid, and also the AstraZeneca product that likely will also be used for treatment. Can I have the next slide, please? So narrowing in on the authorized use for anti-SARS-CoV-2 monoclonal antibodies, this data summarizes, or the slide summarizes the EUA indications for treatment and post-exposure prophylaxis. Again, all of these are for outpatients. For treatment, it's for mild to moderate COVID-19 in adult and pediatric outpatients, those individuals who have positive results of SARS-CoV-2 viral testing and are at high risk for progression to severe disease. In the pre-exposure prophylaxis category, again, it's children and adults who are at high risk for progression, who are either not fully vaccinated or not expected to mount an adequate immune response to vaccination and are exposed to an infected individual or at high risk for exposure. One of the things that happened late last week was that Bamedi did receive a revision of its EUA to include children less than 12 years of age. Both young children and neonates are eligible for both treatment and post-exposure prophylaxis with Bamedi. REGEN-COV and sotrovimab remain authorized for use in individuals 12 years of age and older. And of course, for the pre-exposure prophylaxis, we have the EU application pending for AstraZeneca's product AZD7442, but we currently have no therapies authorized for use in that category. If I could have the next slide. This next slide does show each of the 3 currently available anti-SARS-CoV-2 monoclonal antibodies. I know some of these details are going to be gone over later in this in grand round, so I'm not going to dwell much on this slide, but it is there for your reference, including citations for both treatment and post-exposure prophylaxis effectiveness. But I think the big point here is that for treatment, these are quite effective, really 70 and above relative reduction in all-cause hospitalizations and deaths for these products. And they're also quite effective as post-exposure prophylaxis. All three of them are currently active against the Delta variant currently circulating in California. I can have the next slide, please. Some of the considerations when thinking about anti-SARS-CoV-2 monoclonals, as of late last week with the broadening of the EUA, these products are now authorized for use in high-risk individuals in all age groups. In fact, being less than 1 year of age is now listed as a high-risk criteria in the EUA for VAMEDI, making you eligible for treatment and post-exposure prophylaxis. Additionally, REGEN-COV is available to be given subcutaneously. The other two are available intravenously, but the subcutaneous administration does decrease the barriers to admission to administration of anti-SARS-CoV-2 monoclonal antibodies. If I can have the next slide. In regards to distribution of these products, for the last several months, Health and Human Services has been allocating anti-SARS-CoV-2 monoclonal antibodies to states, and states have been distributing them to local jurisdictions. In regards to California's process, every approximately Monday, we do receive a federal government allocation for each state. That allocation is based on newly confirmed cases and hospitalizations. CDPH allocates products to local jurisdictions using a similar formula based on newly confirmed cases and hospitalizations expressed as a 7-day average. Within each local jurisdiction, a product is allocated by local medical health operational area coordinators. If I could have the next slide, please. Overall, this is the national distribution of these products, showing each of the 3 products and the numbers for each of the distribution weeks. We did have a relatively long week around the Thanksgiving holiday that is extending, but overall, more than 1.6 million total doses have been distributed around the country by HHS. But as you can see from this chart, the quantity of each product varies weekly as to how much is being distributed. For example, sometimes we might not have any sotrovimab at all. REGEN-COV makes up the largest proportion of product allocated by the federal government at 59.6%, and that's followed by VAMEDI. If I could have the next slide, please. Here's the allocation to California for each of those weeks. This follows very similar trends to the national trends. The majority of our product we've been getting has been REGEN-COV with a sizable amount of VAMEDI as well. And we do receive a smaller proportion of sotrovimab. But you can see here both that the numbers of product allocated vary as well as the proportion of each product for each week. Can I have the next slide, please? There are certainly some barriers to operationalizing monoclonal antibody administration, and I know that our next speaker is also likely going to address some of these in the clinical setting. Here are just some that we have heard about and some perhaps solutions. Limited supply of the product is an ongoing issue. This remains a finite amount of product being distributed throughout the state. Depending on overall cases and surges and patient acceptance, the actual scarcity may change from week to week. We're obviously hoping that new product as well as increased supply will help alleviate the scarcity. I would point everyone to the NIH treatment guidelines that include suggestions when product is limited. Another thing that we've heard a lot from providers as a barrier is patient hesitancy. There are some very nice sites rolled out by HHS that can be used for patient education, including Combat COVID, and the link is here on the slide. This includes informational videos as well as a call center and treatment locators. HHS has also made available a communications toolbox that's available on the link on this page. We certainly realize that setting up infusion sites can be very difficult. Giving these products does require bringing patients in, keeping them for monitoring for a duration of time. So both space and staff are an issue. HHS has made available some instructions and resources for setting up infusion sites that are available on the link on this page. Additionally, requests for on-the-ground resources in regards to staffing and space can be made to your medical health operational coordinator. And likewise for the staffing and space constraints, facilities can reach out to their MOOC to see if resources are available to assist in setting up and running these sites. If I could have the next slide, please. I wanted to just briefly touch on the 3 products that we likely will see coming in the next couple weeks to months, starting with AstraZeneca's AZD7442, which is a monoclonal antibody that is long-acting, has shown promising results for pre-exposure prophylaxis. Trials for post-exposure prophylaxis failed to meet the primary endpoint. It is also effective as a treatment, but based on this data, does not seem to be as effective as the other currently available anti-SARS-CoV-2 monoclonals. Molnupiravir is a ribonucleoside analog that is an oral antiviral produced by Merck. It has a relative risk reduction of 30%, and likely will be seeing that rolled out as a treatment of mild to moderately ill outpatients who are at high risk. There's also a trial pending for post-exposure prophylaxis. And finally, Paxlovid, which is co-administered with ritonavir, which is a protease inhibitor, showed promising results, at least based on an interim analysis, with an 89% reduction in the risk for COVID-19 related hospitalizations or death. And likely we're expecting approval for that for treatment of mild to moderately ill outpatients. If I could have the next slide, please. I just wanted to briefly touch on Molnupiravir because this is going to be the first of the oral antivirals really to come out. The effectiveness appears to be much less than available anti-SARS-CoV-2 monoclonal antibodies. So I think we need to keep in mind that while oral options are very attractive, the decreased effectiveness and risk of side effects needs to be taken into account when suggesting use to patients. We are awaiting full FDA approval and an EUA. I think we need to note that studies in animals have shown reproductive toxicity, as well as bone and cartilage toxicity and mutagenicity concerns. So we do expect that the use will not be authorized, or there will be substantial precautions in pregnant individuals and lactating individuals, and we expect that use will not be authorized in pediatric patients. If I could have the next slide, please. As far as timeline and quantity, I do wish that I had a crystal ball and could give everyone a good idea of what to expect and when to expect it. It has been changing day by day, sometimes hour by hour. For the anti-SARS-CoV-2 monoclonal antibodies, for the 3 that are currently available, that's Bamedi, Regencov, and Sotrovimab, there's about 120 to 200,000 courses distributed in all US states each week. For the AstraZeneca long-acting, we do know that there's going to be hundreds of thousands of doses distributed in US states by the federal government. And when that's initially available, it likely will be in very limited supply. We may see that product as early as mid to late December 2021, so it might be coming this month. Moving on to the oral antivirals, Molnupiravir, we know that there's a supply of millions of courses purchased by the US government. We're expecting that distribution to start from the federal government in mid to late December 2021. In regards to Paxlovid, we could see this as early as early 2022. The US government is purchasing, again, millions of courses to be delivered over approximately 10 months and distributed by HHS. If I could have the next slide, please. As far as distribution of these products, we're really striving for an equitable, efficient, and effective distribution. As far as the products that are currently available, that's Bamedi, Regencov, and Sotrovimab. Courses are being allocated using the procedure I mentioned previously. As far as the long-acting monoclonal, the AstraZeneca AZD7442, we had, as I mentioned, unknown number of courses at cadence of that distribution. Initially, we're strongly considering aiming that distribution to transplant centers to ensure that this drug is accessible to the severely immunocompromised and those who are unlikely to respond to vaccination. As far as Molnupiravir and Paxlovid, we have an unknown number of courses for both of these. Likely we'll have a federal distribution to states every 2 weeks. And the distribution will likely be based on new cases as well as an equity measure. And those medications will be going to pharmacies, and those pharmacies will be identified at the jurisdictional level. If I could have the next slide. Just a quick word on Omicron and these therapies. There's very limited data regarding the effectiveness of specific therapeutic products against Omicron. Certainly with the monoclonal antibodies, given the number of mutations on the spike protein, there's certainly a good chance that effectiveness of some of these products will decrease. For the oral antivirals, theoretically, they should be less impacted given their location of action. At this time, we need to remember that Delta does remain the most common variant in the US, and the currently available therapeutics remain effective, though we need to obviously watch the numbers closely, as well as await testing for each of these products to assess their effectiveness as the pandemic changes. If I could have the next slide. Just some quick conclusions. Available therapeutic options do greatly decrease the risk of developing severe disease in high-risk populations. We expect to see several new therapeutic options in the next several months. Additionally, results for ongoing trials addressing pre-exposure and post-exposure prophylaxis, as well as trials in less high-risk individuals, are forthcoming and likely to broaden the authorization of available therapeutics. We do expect that there unfortunately will be limited supply for many therapeutics, especially early on in a product's distribution. And we all need to always remember that therapeutics are not a replacement for vaccination. So thank you very much. I will end there. Thank you.
Thanks so much, John and Erica. Erica, are you still here? Can you pop back on for a couple of questions before we ask Dr. Luetkemeyer to join us? And John, if you'd join as well, that'd be great. Thanks. So can you just give us a sense of, you talked a lot about scarcity, Dr. Openshaw, but can you give us a sense of how we're doing in California? Are we getting the right number? Do we have a lot of excess? Are we really tight? How's that flow going in terms of injectable market?
Yeah, it's very early on in the first couple weeks after the HHS allocation started. There was definite scarcity, and we know that facilities did not have enough. The feedback that we've gotten currently is that has been relieved, and most places now have sufficient amount of product. It's always going to be this interplay between patient demand versus the total number of cases versus the surge. So the number of courses that we're getting in California really has ranged between 6,000 to 10,000 approximately, and that's remained roughly stable. So I think that right now we are I think in a better place as far as the feedback that we're getting. But should we have a surge in cases, we might have to start limiting it again. And I would point out the NIH treatment guidelines that do suggest really doing treatment over post-exposure prophylaxis when we get in those situations.
And just to kind of put a point on it, thanks for asking, Kim, because I think that's really why we wanted to emphasize, and really glad that this today is focusing on therapeutics, because I think especially with some of the shifts that John mentioned around sub-Q, treatment, and we just don't know there's enough awareness out there, and we've had some places turning away product, and we want to really make sure people are really thinking about this as another tool. Obviously, prevention is better, but if we can prevent hospitalization and prevent us going over that tipping point with treatment, but we need to make sure we have enough sites and enough acceptance, both from providers, awareness of providers, acceptance by patients, and utilization. So I think that's definitely a theme we wanted to really hit home around the monoclonals. Thanks.
Great. And then, Erica, you mentioned sites. How are we doing on infusion sites in California? Do we have enough? Are they evenly distributed? Where do we have work to do there?
John, can you take a stab at that one? I think you know more of the details.
Sure. I think that we have, I want to say about 700 that have received product. We do know that, I think that more would always be welcome, and especially as we head into a potential surge. I think we're really encouraging, sites that can operationalize to start operationalizing the use of these products, and reaching out to their MOOCs if they need staffing or other guidance or support where the state can help. We are going to be in a situation where we do have orals coming, but the first one coming is quite a bit less effective than the monoclonals, and so those really, I think, are our best options. So I think that making this as widely available to as many patients as possible is an important goal.
Great. And just for those of us maybe in independent private practice, is that CDC site, I think it was a CDC site or a national site that sort of said where all of the infusion sites are, or the word MOOC rolls off your tongue, but not mine. So, where do you even, if you're a person who's never reached out to your MOOC before, how do you find out who your MOOC is? Just to get really practical for the physicians and providers on the call.
So that HHS site has a map and an infusion center locator, as well as a whole host of patient educational materials. For contact information for the MOOCs, if you look at my slide set on each point where it is mentioned, there is a link to a contact list that, depending where you're located, will give you an email address that you can reach out to.
Fabulous. Yeah,
I can give a teeny bit more context to the medical health operational area coordinator is typically, it's sort of a combination of EMS director and health officer. In many jurisdictions, the lead is the EMS agency, and then that link will give you the places. But really, if you work with your EMS agency and or local health department to look on those sort of sites and resources, that is who you can work with to help set up sites or get onto the allocation distribution.
Okay, great. That's helpful. And are these products available? Are they expensive? Are they available with or without insurance? How are patients paying for these?
The product themselves are free. They have been purchased by the federal government. Insurance will reimburse for them. Most centers will either bill insurance or charge patients. And there is on the HHS and ASPR site, there is a specific site linked to billing that will actually provide the reimbursement for each of those services. So I would point people to the HHS ASPR site. It's the site, when you look at resources for infusion centers in my barrier slide, there will be a billing section there.
Okay, great. And then just before we move to our next speaker, I would like to just ask one sort of general question that's really on all of our minds. So any changes in recommendations for household gatherings? It sounds like the approach is certainly, test before, test after. So that's a big deal as we go into the holidays. Watch the numbers, the local numbers, watch how Omicron's spreading. If you have a household, for example, where everyone's vaccinated, everyone who is eligible is boosted, but you have some under fives, should we mask inside? So talk just briefly through that.
Yeah, no, really important, I think, and you alluded to a lot of it, but I'd say, yes, if everyone's vaccinated, then I think can feel, much more comfortable around that. I think testing is another, sorry, I just don't have the key. Is another really important tool. I think for the remaining children under 5 or people who are, immunocompromised or elderly, I do think if they can continue to wear their masks as much as possible, good ventilation again is really important. If you can, I know it's getting colder, but we are California, it's better here than many other places. If you can really keep some windows and doors open, maybe the people who are unvaccinated or are immunocompromised can sit closer to the ventilation. I think those are all kind of things. Keep it shorter for those who are maybe more vulnerable. Those are all other things I would take into consideration. And again, I think asking other people to be vaccinated and tested before they show up, if you're the one hosting, are all really good tools. But we also recognize, it's been a long 2 years. People want to see their families. I know I'm excited that my, kids are going to be able to have Christmas with their grandparents again, which they weren't able to do last year. So, but I think those are other tips that people can keep in mind.
Great. Really helpful. Thank you to you both. I'm going to now welcome back Dr. Annie Lutkemeyer. If the two of you are available at the end for more Q&A, we'd love that. If not, we completely understand. So let me just give a brief introduction to Dr. Lutkemeyer. Annie is a professor of medicine in the Division of HIV, Infectious Diseases, and Global Medicine at Zuckerberg San Francisco General Hospital at the University of California, San Francisco. She leads clinical trials examining novel therapeutics and preventive strategies for COVID-19, including antivirals, anti-inflammatories, convalescent plasma, and vaccinations. Dr. Lutkemeyer has been busy. She co-chairs the UCSF Interventional Clinical Trials Committee and is the principal investigator for the UCSF Coronavirus Prevention Network and the UCSF AIDS Clinical Trials Group. We're so grateful for your time, Dr. Lutkemeyer, so why don't you go ahead and take it away.
Thank you, and I think you guys are going to run my slides if I'm not wrong. There we go. So I caught the last half of John's excellent presentation, so there might be a little bit of overlap here, but hopefully I can present this, share my clinical perspective, as I've been one of the folks helping to get our site up and going for monoclonals and have been part of some of the studies to develop and test monoclonals in clinical trials. Next slide. So these are my disclosures. Next slide. So this is going to be way too basic after Dr. Openshaw went through all the discussion that he did, but it's sometimes helpful when we talk to our patients just to take a step back, just like MOAC rolls off the tongue. Sometimes monoclonal antibodies roll off the tongue for us, and it's helpful just to remind our patients of what we're talking about here, and that monoclonals aren't new. They're a new treatment for COVID, but we have more than 100 monoclonals are FDA approved for a whole variety of treatments, mostly in the cancer and autoimmune disease range. So sometimes people feel more comfortable when they recognize that these have been given for other reasons. And as Dr. Openshaw pointed out, we have at least 3 combinations right now that have emergency use authorization for use outside of the hospital. And this is just a little schematic of where the antibodies work in a cartoon way to help block entry into the human cells. Next slide. So as Dr. Openshaw went over, I just want to highlight what we do currently have available. We have the Lilly combination that targets the ACE2 receptor, and this has an EUA approval for both treatment and for PEP. It binds to different but overlapping epitopes. This was the first combination that we had available in the US. And we know that there was decreased susceptibility with beta, gamma, and maybe with Omicron. A lot of this is speculative, but that may be the case. But as was pointed out, there is preserved efficacy with Delta, and the Lilly combination was actually brought back and allowed to be used again under EUA during the current Delta surge. So right now, Delta is the majority of the infections in the United States, and so we should feel comfortable using this until we get more data that more definitively tell us that we can't use the current monoclonals. The second one is the REGEN-COV, which is the casirivimab and imdevimab, also approved for treatment as well as post-exposure prophylaxis. Like the Lilly product, it also targets the ACE2 receptor, but it binds to non-overlapping sites, so it's not exactly the same as the Lilly combination. There's some questions about decreased susceptibility to Omicron, but again, all of these are pretty speculative early days, and what we'd really like to see is some pseudo neutralization assays, and even clinical data would be terrific. But at this point, we're using the data that we have, extrapolating about the existing spike mutations. Sotrovimab has an EUA for treatment. This one acts slightly differently. It targets a highly conserved epitope on the spike protein from actually SARS, the original SARS. It does not compete with the ACE2 binding, receptor binding, and it does have some amino acid substitutions in the FC region to extend the half-life. Again, speculation, but looks like it may have preserved activity with Omicron when you look at the individual mutations, but we look forward to getting more robust data to help shore up our support here for use in Omicron if this becomes more widespread. And then Dr. Openshaw did mention the AstraZeneca combination, which is a little bit more similar to the Lilly and Regeneron combinations, but good to know that it can also be given IM, and it binds to 2 non-competing sites. It's quite long-acting, may last up to 12 months. And again, it was speculative, but we hope that it has preserved activity against Omicron. One thing that I didn't mention about sotrovimab is that there are data that have just recently been released that the IM formulation looked equivalent to the IV formulation. It's only approved for IV formulation, but I believe that they've probably taken this to the FDA, and it will be, if approved, will be available for use IM as well as IV. And this may help in terms of logistics. Because being able to do anything besides an IV, I think, can be really helpful on the ground as you try to set these programs up. Next slide. So just a reminder of the big picture here, how to think about who we want to treat. This isn't everybody. We really target higher risk outpatients. But to make the comment that you can treat hospitalized patients, but only if they're hospitalized not for COVID. And sometimes that feels like you're parsing things a little bit. There's certainly, we've had examples in our system where, someone is admitted with a broken arm or, something entirely unrelated to COVID, but they do have mild symptomatic COVID and are in a higher risk category. So it is appropriate to give them therapy while hospitalized. You want to treat them within 10 days of symptom onset, but most of the data support that we should be treating people as early as possible. So if we can shift that earlier, it may be more effective. And as Jonathan mentioned, the relative risk reduction ranges, but it's in the 70 to 85% range for reduction of hospitalization and death. Important to remember, though, that the overall absolute risk reduction is 2 to 6%, and that the hospitalization rates, depending on the study that you look at, are anywhere from 5 to 7% and as high as 10% in some of the earlier studies. But the vast majority of people are not hospitalized at the end of the day, but we're just looking to reduce the likelihood of hospitalization in people who are higher risk. They're generally well tolerated. They do require some medical infrastructure to provide the treatment, either as an IV or subcutaneous administration, and they do require a monitoring for up to an hour. This may be reduced down to 30 minutes with some of the coming formulations. And the reason for this is to monitor for a very rare allergic reaction. But again, similar to the vaccinations that we give, we do want to have the ability to treat people should this occur, and it has been described in the clinical trials that very rarely people can have an allergic reaction. As I think John mentioned, most of the data that we have comes from unvaccinated patients. We have very limited data for fully vaccinated patients, although we do know that they certainly develop breakthrough infections and can end up in the hospital, and we worry about our higher risk patients doing poorly. For this reason, the EUAs do allow the use of monoclonal antibodies in breakthrough infection. And I'll say that clinically, when we're evaluating people for treatment for monoclonals, we think about their vaccination status, but certainly if I'm seeing someone right in front of me who's older and has multiple comorbidities and has symptomatic COVID despite being vaccinated, we will offer them monoclonals on the basis of their risk factors. And we feel reassured that they're vaccinated, but that certainly doesn't guarantee that they won't have complications there. So we do offer to fully vaccinated patients with breakthrough. We worry more about our unvaccinated patients, obviously. Next slide. So what are the risk factors? Just a reminder, and again, forgive me, I wasn't on this part if Dr. Openshaw went through this. I'll keep this part brief, but a reminder of what counts as higher risk for severe COVID. So just on the basis of being 65 alone counts, or 12 years old with one or more of the following. And I didn't update this based on last Friday's change, but as Dr. Openshaw pointed out, the Lilly combination is now approved down to birth in a weight-based, with a weight-based adjustment. So this is available for pediatrics but only for the Lilly formulation. But for all others, it's 12 years old and older, and all of these count as risk factors for severe COVID. So overweight, which has been reduced down to a BMI of 25. Pregnancy, there are no pregnancy-specific clinical trial data, although this has been approved under the EUA, and observational data thus far, I think, are reassuring, although, and we certainly recognize that pregnancy can be quite high risk for women with symptomatic COVID. So it's always a shared decision-making here, but worth having the discussion with your pregnant patients if they have symptomatic COVID. Other common risk factors: chronic kidney disease, diabetes, heart and lung disease, including chronic lung disease from COPD or interstitial lung disease, immunosuppression, sickle cell disease, neurodevelopmental disorders, and then medically related technology or dependence. And then just a reminder that there's sort of this gray area that really allows for investigator or clinician discretion, other medical conditions or factors that may put patients at higher risk of progression, and this does include race and ethnicity. So that I think that there's a lot of leeway to offer treatment to people who you think might be at risk of progressing to more severe COVID. Go ahead. Next slide. So post-exposure prophylaxis, this is just a reminder of what the current NIH guidelines advise about post-exposure prophylaxis. Again, 2 of the agents are approved for this, so the Regeneron combination and the BAM-Edi-Lilly combination. And this isn't for all comers. It's limited to those who are either not fully vaccinated or who are not expected to mount an adequate immune response to COVID vaccination. In other words, that they're immunosuppressed in some way. And they have to meet criteria for a higher risk exposure. So within 6 feet for 15 minutes or more to someone with COVID, or at high risk because of occurrence of COVID in some institutional setting, so a nursing home or a prison. And where this last bullet point starts to feel like pre-exposure prophylaxis versus post-exposure prophylaxis has certainly been raised, because I think that is a bit of a gray area. Nonetheless, in the data that we have, this is one study looking at the Regeneron combination. It reduced the risk of symptomatic disease and household contacts from 7.8 down to 1.5%. So certainly something that should be considered. And again, from an operational point of view, one thing that we have tried to start doing with our patients is when we're seeing people for treatment for their COVID, asking them about people in their household who may be unvaccinated or who may be at risk for not mounting an appropriate response due to their immunosuppression as a way to screen for people who would benefit from post-exposure prophylaxis. Next slide. Dr. Openshaw mentioned this, so I won't go into this in detail, just that the AstraZeneca drug has been studied in the PROVENT trial for people who are at higher risk, including by age or by other risk factors, and there was a 77% reduction in symptomatic disease. And I think, interestingly, remember, this is the agent that has a very long half-life. They released recent information or follow-up data where they looked at 6 months after administration, and they still saw a persistent 83% reduction in the risk of developing COVID. So the long-acting nature of this compound may be really quite beneficial for people who are in high-risk situations. I think the flip side of this is for people who are not vaccinated. Right now, what we tell people is to wait 90 days after getting a monoclonal antibody before they get vaccinated. Certainly, we want everyone to get vaccinated, as was well pointed out, that that's the best way to prevent disease. I think it's going to get a little bit tricky for unvaccinated patients if they're getting quite long-acting monoclonals to understand when they can be offered vaccination. But that's something we're going to have to address with our patients as we understand more how long vaccination may be impacted. And the fact is that our data on to inform how long we have to wait are really speculative. Really wish we understood that a little better at this point. Next slide. So just some comments about the logistics of programs to get monoclonals set up. As I mentioned, the location, you have to have the ability to administer drug, monitor for the rare allergic reactions. and have the ability to safely see infectious COVID patients, and that's usually one of the biggest challenges here. Places to leverage include EDs, urgent cares, outdoor testing centers where you can pair testing with treatment, and many locations have also been able to leverage infusion centers that have COVID positive capabilities. So, respiratory isolation centers. Mobile van and home services exist, but they're not always widely available. They tend to be a little bit more feasible for private pay patients, although there is you can search for the availability of these services online. And as Dr. Openshaw mentioned, on the Combat COVID website, there is a call center that patients can call to try to locate monoclonal infusion centers near them. I wanted just to mention briefly the route of administration as well, because tasirivimab and imdevimab, the Regeneron combination, is a sub-Q option. And I just wanted to point out that we have limited data for sub-Q administration for treatment. It is permitted by the EUA if IV infusion would delay treatment or is not feasible. The concern here is just that sub-Q may have more delayed bioavailability versus giving it the medication IV. And they have not been compared head-to-head in a rigorous way. It was nice to see there was an observational preprint that came out at the end of last week, and again, non-randomized, but that showed hospitalization and death rates were similar in those who received sub-Q Regeneron versus IV, so 2.8 versus 1.7. And then they also did have a cohort where they just compared people who had received sub-Q versus no monoclonals, and they saw a fairly robust reduction here. So I think this gives us some support that sub-Q is reasonable to pursue, and certainly is logistically preferred in many non-emergency room settings. If you just can't get an IV set up, it's certainly better to give sub-Q monoclonals than to not give them at all. And as I mentioned, sotrovimab, based on data out of COMET-TAIL, has some data for 2 gluteal IM shots being non-inferior to IV. So this may be an option as well. I think nobody loves an IM shot, but it can be easier to administer than an IV. Next slide. So Dr. Openshaw covered the molnupiravir data. So just a reminder of where things stand here. I think we saw the exciting 48% relative risk reduction that was a little more disheartening when it decreased to 30% with the full analysis set. And just a reminder who was treated in this molnupiravir study, which was called Move Out. People with mild or moderate COVID, so with an O2 sat of greater than 93%, and similar to the monoclonals, 1 or more risk factor for severe COVID. So age greater than 60, obesity, diabetes, or coronary artery disease. They had to be unvaccinated, but notably about 20% of them were antibody positive. And this was pretty soon. So symptom onset within 5 days. They had to receive their treatment within those 5 days, and notably about 50% had symptom onset within 3 days. And if they did qualify, they were treated with 5 days of molnupiravir given twice a day versus placebo. And the study was stopped early, but with the larger analysis set, there was a drift in the relative reduction of hospitalization or death down to 30%. Next slide. So how do we think about comparing these two? As Dr. Openshaw pointed out, molnupiravir is not FDA approved yet, although the FDA Advisory Committee did vote to recommend that the FDA approve it, and I think we're waiting to see what the FDA's action will be, although I think that typically the FDA does go ahead and support what the Advisory Committee has recommended. Well, clearly the efficacy of molnupiravir is, at least based on the Move Out data, is much less robust than what we see with the monoclonal antibodies. And if this holds the same, then you'd need to treat about 30 people to keep 1 person out of the hospital. If you do the same calculations with monoclonal antibodies, it really depends on which study you look at, but the number needed to treat is as low as 15, but can go up to 45 depending on which study you look at. But I do think all in all, the overall relative risk reduction in hospitalization has been much more robust in monoclonal antibodies than it has been in the outpatient study for molnupiravir. We think that the impact of Omicron will probably be minimal on molnupiravir, and there may be an impact Omicron on some of the monoclonal antibodies, as I mentioned, but this may depend on the specific monoclonal, with Regeneron and Lilly being more affected, but again, that's speculation. I think that when we have molnupiravir widely available, when that happens, I think there still will be supply limitations. This will probably be prioritized for most patients meeting higher risk criteria as long as they're within 5 days of symptoms. But from a clinical perspective, I'm still going to be reaching for monoclonals and those who I think who are at the highest risk if they can come in and be treated. And that will include people who really have advanced age or who are immunosuppressed, particularly if we only have molnupiravir available. Once Paxlovid is available, if the data still look as robust as they look, this calculus may change. But for people that you're really concerned about at this point in time, I think we're going to want the monoclonals. I just want to point out that monoclonals are going to be the only option as well for people within who've had symptoms 6 to 10 days prior to treatment. Whereas molnupiravir, we can really only give it within 5 days of symptoms. And indeed, for the study that I mentioned, they modified that study after phase 2 when they found that going out to 7 days looked like it was really going to be less efficacious. So the sooner we can give molnupiravir, the better. But if you are within 6 to 10 days of symptom onset, you're probably going to have to shift to the monoclonal antibodies. As I mentioned, for both of these agents, unvaccinated populations are the highest risk for disease progression and have the most data to support use of either monoclonals or oral antivirals. But it will be very reasonable to treat vaccinated patients as well if they are at high risk, as it will likely reduce symptoms, transmission to others, and may help avoid hospitalization. But we certainly will welcome data in vaccinated populations. Lastly, who do we want to avoid treatment in? As Dr. Openshaw mentioned, pregnant and breastfeeding women and women trying to conceive will not be target populations for molnupiravir, given concerns about teratogenicity, and will likely not be approved in pediatric populations, given limited data. Monoclonals have logistic challenges for those who are unable to come to an accessible site for treatment and monitoring. And we're going to have to keep a close eye on any changes that may occur with susceptibility with Omicron, particularly if this becomes more widespread in the United States. Next slide. So I'll go ahead and stop there, and I'm happy to take time for questions.
Thank you so much, Dr. Lukemeyer, and John and Erica, if you're still here, please feel free to hop on. Annie, that was really helpful, and I just have a few questions that came in. If we see an increase in Omicron sort of at the same way we have in South Africa in our country, how long might it take to understand the changes in susceptibility to Omicron in these medications? How long does that process take?
Well, I just want to point out that we first heard about Omicron the week before Thanksgiving, so it's really only been 2 weeks. I know it feels like it's been, everybody's sick and tired of hearing about it. So we really don't have the information we need. I think we're going to have that information soon, but it's going to take at least a few more weeks, and it may take up to a month or two. So the good news is, though, as Dr. Openshaw points out, is that right now in the United States, it's mostly Delta. We know we have some Omicron here, but it's mostly Delta, and we know that the monoclonals work quite well for Delta. So I think that we have some time to get this sorted out. There's no reason to, wholesale abandon any of these monoclonals. They work. We should be using them in the right populations. And my hope is that in the next month or so, we'll really have a much better sense. And that's been a huge priority. People have really swung into gear to understand this.
Great, amazing. And then that was such incredible in-depth information, and I'll certainly review it for the details. But if I'm a patient in your office and I'm saying, I understand this, with the injectables, there's the rare risk of the allergic reaction, but what other side effects am I going to anticipate with monoclonal antibodies?
Most people tolerate this really, really well. We give them the monoclonals, we monitor them afterwards. Occasionally people can get a little bit of a rash after the infusion. What we worry about is a severe allergic reaction, but beyond that, if they walk out and they're doing well, we usually tell people you should be just fine. But we to come back in if they have signs or symptoms of their COVID getting worse. The other piece we just have to remind them about is that if they have not been vaccinated, that right now the recommendation is to wait 3 months to get vaccinated. Again, that's an area where we really want more data. That's a bit speculative, that 90 days, and it's probably going to be different with different agents. But for right now, they would need to put vaccination on hold, as uncomfortable as that feels to tell anybody to put getting vaccinated on hold. But they do need to remember that.
Okay. And John, you had alluded to the fact that there is some patient fear to use monoclonal antibodies. It sounds, from what we're hearing here, like they're quite safe. Is there any word on the streets, like we're seeing in vaccinations, that may or may not be completely false, that you have heard, any of you, that we need to be prepared to address as physicians? Presumptive side effects or worries. If not, that's fine, just wondering.
I don't think that I've heard anything. I've heard from providers that some patients are offered and turn it down. I think that it's a product with an EUA. It's not technically an approved product, and that does give some people worries. I think on the other hand, we're dealing with the pandemic where people take ivermectin, and so I think that there's a lot of things out there, and I wouldn't say that I have a bead on all of them, but I think monoclonals I think we do need to say that monoclonals are the only really outpatient treatment that really has a substantial amount of evidence behind them for effectiveness.
Yeah, great, amazing. So just another question for you, Dr. Pan, on sort of a different tack. Some people were asking how much influenza we're seeing this year, and is that robust, and we're seeing hospitalizations for that, and then also how closely is it mirroring the constituents of the vaccine that we have this year?
Yeah, I can definitely speak to the former. I'm going to need to get back to everyone on the match, which I feel like I normally know this time of year. But as far as what we're seeing, it is somewhere in between. So last year, I would say our flu surveillance was like flat. It just was like so little. And now it's like a little bit higher, but compared to other seasons where it's really starting to go up and peak, and often in California we don't really peak until January or February or so. So it's definitely much lower activity than typically in prior flu seasons prior to COVID. So we're hopeful it will stay that way. But you also may have heard there was a large outbreak in college students in Michigan. We did send out a health alert around that recently. So it certainly could be coming. And then the match, I do know we're mostly seeing H3N2 this year, which also sometimes forebodes like that's certainly a more typical severe flu strain than the H1N1s in most years, but and Annie may know, but I actually don't know off the top of my head about the match this year.
Anybody else?
I was just hearing someone talk about it, and I remember them saying that they thought that this wasn't as good of a match, but I would want to know more.
Okay, well, we'll circle back to that as the flu season evolves. So thank you for that. And then one other question on Delta, since we still really are sitting in the middle of a Delta surge, if you will, or at least that's our predominant strain. Do we have data on breakthroughs after the booster in Delta? Dr. Pan, Erica, you said there definitely is evidence that there are people who got Omicron have been boosted, but what do we know about boosters and Delta breakthroughs?
I have not seen external data on that. We are just starting to look at it in our own data. And we've been doing some work on sort of all these general questions around that. Who's got evidence of PCR, confirmed infection, compared to previously vaccinated, et cetera. But we're about to start incorporating that booster data, but I have not known, and certainly anecdotally have not heard it at the same level that we're hearing with Omicron. Certainly a lot of these initial cases with Omicron have actually been boosted. So yeah, I think more to come unless others have heard other data.
Yeah, okay, great. Well, I really do want to thank you all for being able to be here today. I'm just going to have a preview that we are going to continue this series, which has been so important. And our next webinar is on January 11th. We're going to dive deeper into therapeutics. At that point, there'll be more data, maybe some more availability, as well as the usual updates on what's happening. I'm sure there'll be a lot more news and information on Omicron at that time. So please do join us then. And I'll also mention that we're going to shorten, we've been really appreciative of all of you who have stayed for these 1.5 hour long seminars. Our plan now is to shorten them to an hour just because we're all so busy, and really try to keep the information flowing, but have a shorter thing so it's more reasonable to get back to your day. But you always can come back to our recordings of these, which are available at covidroundca.org. And finally, just a message that for any of you on this call who are interested in being COVID vaccinators, the state is reimbursing up to $10,000 per site for up to 5 sites. So please do visit the website calvaxgrant.org for more information on that. Again, I just really do want to thank you, Erica, John, and Annie, for presenting the content today, for keeping us up to date, for all the hard work you've been doing for so long. And thanks to everyone for listening in. Stay safe and happy holidays.